is going to press out the round window. Okay? It's round shaped instead of oval shaped. Okay? So this kind of acts as a release valve, just like if you've ever had those little toys where you squeeze their tummy and their eyes pop out. Right? So you push pressure here, the eyes pop out, so that relieves the pressure. That's what's going on here. Now, all of this has been the decompression wave, or the compression wave, excuse me. So we've all pushed forward through these different chambers, through these different fluids and membranes. After we've reached the peak of that compression wave, now we decompress. We go back the other direction. Just kind of like I mentioned in lab, when you have waves on a beach, whether it's for a lake or ocean, you have the wave come in, and then you have the wave go back out to the body of water. Now, as we go through the decompression wave, it's doing everything just in opposite. So that membrane of the round window pops back in. That's going to displace the perilymph of the scala tympani pressing against the basilar membrane. Basilar membrane presses into the cochlear duct, displacing the endolymph. That is going to shift the vestibular membrane back into the scala vestibuli, filled with perilymph, and that's going to push back out against the oval window. So everything in the opposite direction. And as we mentioned, when we have that decompression wave, that's when we're going to have sound occurring. So what happens is we have that organ of Corti or spiral organ, which is a combination of this little box right here. This is the spiral organ. So as that basilar membrane comes back in, you've got the tectoral membrane floating in the cochlear duct. It just has that one anchor point and it just flappies around. As the basilar membrane comes back in, it's going to end up hitting the tectoral membrane. That's why it's called tectoral. Tectoral means touchy. Okay, so that's the membrane that touches the basilar. When it hits, we're going to bend the hair cells. So we're going to have all these little hair cells that are stuck in that basilar membrane. And these are mechanoreceptors. So again, we learned mechanoreceptors get turned on by touch. So we hit the hair, bending the hair. That's going to open a sodium channel. Sodium rushes in, potassium rushes out. We've just converted sound waves into an action potential. So now we can process it and eventually hear what was going on. So again, no matter what we have as a sensation, whether it's touch or vision or hearing or anything, we have to convert that sensation to a action potential so we can get it to the brain so we can process it. Okay, so that decompression wave will follow that compression wave. Everybody's moving the opposite, and that's when we're going to get our tectoral membranes slapped. So there's our tectoral, there's that basilar with all the little hair cells, and that's where we do some slapping action. So we can hear things. Okay. This is just a fun picture because they're trying to draw sound waves. So like, imagine it's vibrating. So the whole process of hearing, we have those sound waves that are going to be focused into the external auditory canal. Bless you. It's going to be amplified by the tympanic membrane. That's going to vibrate the malleus and then the incus and the stapes. That will push on the oval window. Those little sound waves will come in, and they will go across the vestibular membrane into the cochlear duct, pushing the basilar membrane into the scala tympani, where they pop back out the oval window out there. And then, of course, the decompression is the opposite. Now, it's important for the pathway to be completely clear. That middle ear cavity has to stay a cavity. If there's anything in there, that can interfere with these bones vibrating. That can interfere with this round window popping out. So this is why if you get water in your ear or you have an ear infection, sounds are muffled or you may not be able to hear properly. When you have that infection, when you have that fluid buildup, that fluid may be preventing these bones from vibrating properly, or that fluid may actually block, if there's more of it out here in this cavity than in here, it will block the round window from pushing out, and you won't be able to generate a big enough wave to stimulate to slap those hair cells. So that's why any kind of fluid in that middle ear cavity, whether it's infection or swimming or anything like that, can cause problems. So kids who have those frequent ear infections, they'll put tubes in their ears. That tube goes right here in the eustachian tube or the pharyngeal tympanic tube. So any fluid will drain into the nasal cavity so you can get rid of it. And again, this is why you don't feed babies under a certain age on their back, right? You always tilt your kid up when you feed them with a bottle. Because if you lay them on their back while they're sucking on it, it could actually slosh up into this middle ear cavity, causing ear infections or problems with hearing for that kid. So up until a certain age, you have to tilt them so no sloshing into places it doesn't need to slosh. Now, as we travel through the cochlea, again, they've kind of simplified it. That cochlea is coiled like a snail shell. As we go through, the membranes are going to be different thicknesses. And when we look at sound waves, your high-pitched sound waves can't travel very far. So they're going to have to U-turn very quickly. Low-pitched sound waves can travel much further. This is something you might have noticed if anybody in your area always has their radio up really loud when they come home. Anybody have a neighbor like that? You hear them coming a mile away?
The neighbor.
Yeah. In my house, it's the neighbor because my radio is at the perfect volume. It gets louder as you get older because, but again, usually when you hear somebody else's, or if you're parked at a stoplight, what do you hear from the other person's radio that's next to you? Do you hear high-pitched noises or do you hear low-pitched noises?
The bass.
You feel the bass, right? It, moving around like midgets in the back seat wrestling. I can't go into the rest of the song because that's the nicest part of that song, right? Eminem. Look at that, kids. Apparently he's canceled every 5 days because people listen to his words and like, all right. But anywho, when you sit next to somebody that has their bass up, they do have other parts of the music. They're not just listening to boom, boom, because that's boring. There's somebody screeching somewhere, especially if it's heavy metal. But high-pitched sound waves can't go through solid objects very easily. And so if their windows are up, the only thing that can make it through their car is the bass. Basses can go through solids much more efficiently than high-pitched noises can. And again, this is why if you're in a classroom and you hear the next person, you usually hear the basal tones of that person's lecture, not the high-pitched parts of that person's lecture, even though they are usually not lecturing monotone because that would put you to sleep. So basses can go much further. The same thing happens in the cochlear duct. Basal sounds go much further before they make their U-turn, where your high-pitched sounds have to U-turn much earlier. And this is how we can hear multiple sounds at the exact same time. So whenever we have that sound wave cross here and stimulate the basal membrane here, the hair cells here, the brain is going to interpret, oh, axon 5 just fired. That must be a high-pitched note. If we stimulate one down here, the brain's going to be like, oh, axon 29.2 fired. That's a low pitch. So you can have multiple pitches picked up at the exact same moment because those sound waves, it's not just one sound wave, it's multiple going through, and where they're crossing over, they're stimulating different hair cells and the brain picks that up as those different notes that we hear, much like instruments playing at the same time. So this is one of the reasons why we can't hear certain high notes and we can't hear certain low notes. Our cochlea isn't big enough to hear all the low notes out there. So if you have an animal that can hear a lot of low pitch, low frequencies, they'll have a much more coiled cochlea than us. If you have an animal that can't hear as low, they're not going to have as coiled. So you can look at an animal's cochlea and predict what kind of sounds they can hear just by the shape of that cochlea. So this is how we guesstimate some of the sounds that dinosaurs made. We look at the cochlea of the dinosaur so we can guess what they could hear. So obviously they're not going to make noises they can't hear. And then of course we look at their vocal structures if there's any of those fossilized to see what sounds they actually make. So we can put those pictures together. So again, there's a lot of stuff we can't hear because we don't have enough room. Those low notes hit the back end of the cochlea before we can process them. So if you've ever been around animals, anybody been around elephants? If not, go to the zoo. Oklahoma, I think, is the closest open. Oh, there's also Albuquerque, but Oklahoma has a lot of yard by their. Anybody been to Oklahoma Zoo? It's nice. Don't get off the path too much because they do have a lot of wild poison ivy. So like, how'd you get poison ivy? I stepped off the path at the zoo. Like, yeah, don't do that. Things will get you. But if you go around the elephant enclosure, if you stand on the grass next to their pen, you can feel them talking sometimes. Because elephants use a lot of low-pitched frequencies. They can communicate 2 or 3 miles away to other elephant herds through low pitches. You can't hear them because those low sounds are actually vibrating through the ground. It's one of the reasons why they have such big flat feet. So whenever they hear those sounds, they're not hearing it transmitted through air. They're actually hearing it transmitted through the ground and shaking their body. And if you notice, their front legs are almost even with their ears. So it actually vibrates up their body to process. Right? This is also how snakes hear. So a lot of people are like, oh, snakes don't have ears, so they're deaf. One, they do have ears. They don't have ear holes, but they do have ears. They can hear things. How they listen is they put their jaw on the ground. So when they put their jaw on the ground, the sound waves vibrate up their jaw and go right to their ear. So you can tell if a snake is listening to you because he'll tap down to see if he can hear you properly. Which is why you don't see a lot of snakes when you hike. They feel you coming and they're like, oh man, big thing. and they run away. So, a lot of fun stuff with hearing. So our basilar membrane is going to vibrate with those hair cells getting slapped. And again, that combination of the tectoral membrane, the basilar membrane with its hair cells is the organ of chordae, our organ of hearing. So we can, again, set up those action potentials so we can hear the sound and transmit that into an action potential. So from the cochlea, we're going to travel down the cochlear branch, hence the name cochlear branch of the vestibular cochlear nerve, coming in with the vestibular cochlear nerve 8. And again, that nerve comes in at the junction between the medulla and the pons, which we learned back in A&P1. So as it passes through the medulla, it's going to travel up through the midbrain, so the cerebral peduncle. It's going to bypass or go through the inferior colliculus. That's where we learned our auditory reflexes are. That's why we shy away from loud noises or loud noise, high-pitched noises, and we kind of lean if it's too quiet. And then we're going to synapse onto the thalamus where those third order neurons are. And from the thalamus, they're going to go to the auditory area found in the temporal lobe of the brain so we can process the pitch and rhythms and such. Yes, ma'am?
You know how like people with autism, they're more sensitive to loud noises well sometimes? Does that have anything to do with that?
No, it's just how they're responding to being stimulated. So their brain processes things, I don't want to say more acutely, but they just respond stronger to certain action potential. So nothing really to do physical. Autism isn't a physical disability, it's a processing disability. So kind of like being a sociopath. Don't go around telling people that Ms. Lamb just said autism people are like serial killers. But again, these are emotional disorders, brain firing disorders. So there's nothing physically wrong with them. You can't point at someone who has autism's brain and go, look, autism. But it's how it functions. Which I don't want to say stigma, but the thought of autism is kind of losing its momentum because if you listen to anybody, now we have to call them neurodivergent, and then it's, well, everybody's neurodivergent. We used to just call that personality. Back in the day, it's like, you got a quirk. Now it's like, I'm neurodivergent. You're like, all right, you just have to straighten your peas before you eat them. Nobody really cared, but the more we find out, the more we want to label stuff, because that's what we do as people, right? Yeah, people label. That's what we do. And then we complain. Don't judge me. But as a person, we all judge. Crazy. So, yeah, so they're just responding more strongly to the signals coming in. The signals aren't changed or anything like that. Some people have the same violent reaction to country music.
What?
Not really violent, but it's like, whoa. Okay, that's my kids. They're like, why are you talking about the drunk horse that cheated on you? Because I like the country music from the 80s. Today's country music is not really country music. Right? It's just weird rock. So sound waves. When our sound waves come in, if they were to pass directly from the air to the oval window, they would not have enough oomph to do anything. They have to move fluid and membranes and fluid and membranes and fluid and membranes. And that is not enough push from just sound waves alone. We have to amplify them to get enough push to generate enough force to cause that compression wave. So that's why we have the tympanic membrane, that eardrum. That eardrum is going to amplify them. Now, when we compare it, the eardrum is roughly 22 times the size, has 22 times the surface area as the oval window, which means it's going to amplify it 22 times than what the oval window would be able to do without it. So basically, it's like cranking up the volume. So it's going to amplify those sound waves, make those sound waves bigger so they can push all those fluids properly. So again, this is why if you have damage to the tympanic membrane or it's completely ruptured, your hearing goes out the window because you don't have that amplification. And those ear bones are going to help transmit those waves more efficiently. Instead of them scattering in the middle ear cavity, we can take that amplified sound wave and direct it straight to the oval window instead of just hoping that it gets to the oval window and where it needs to go. So our tones, the differences in pitch are related to the differences in the width of the basilar membrane, which is what I just showed you when I had the picture up there. So different sound waves are going to vibrate different parts of the basilar membrane, and that's going to stimulate different hair cells, and that's going to set up different action potentials. that give us those different frequencies that we're able to come in. Again, low frequencies have very wide waves, not a lot of difference between the peaks and the valleys, so they can go long distance, they can go through solids, that kind of scenario. High pitched frequencies have very high and low valleys and peaks, and they are going to happen very, very fast. So they disperse quicker. So those low waves can go further in the cochlea, and those high pitched can't before they have to go through. Now, loudness is determined by the intensity of the sound, how big the sound is. So a low, loud sound still looks like a low sound wave, but it's faster, it's more intense. A high or loud high pitch is still high peaks, high valleys, but it's going to come in at much quicker, much more intensity. So our high tones, high pitch, high frequencies, they're going to have the sounds pass through the basilar membrane near the stapes. Here, it's going to be thin and tight. Just think of when you pull a rubber band very thin and tight. If you pluck it, it makes a high-pitched hum when you do that, because the tighter you pull it, the higher the pitch you're going to get with that. Low tones, pitch at the apical end, closer of that cochlea. There, it gets thicker and looser. You can do the same with that rubber band. Pull it as tight as possible and pluck it. Going to have a high tone, slightly loosen it. The tone gets lower and lower and lower until you can't hear it anymore, or it doesn't make a noise because it's just too loose. So lows are loose and your highs are tight. Okay, so pretty straightforward. Ooh, deafness. So if you can't hear the tones, so we have 3 different types of deafness. Each one is going to have a different area that has been damaged, a different area that's not functioning properly. So our first one is conduction deafness. We have problems conducting the sound waves from the air to the basilar membrane, to where we can stimulate those hair cells. So problems with doing that compression wave and decompression wave. So before it becomes an action potential, before it becomes a nerve issue. So sound waves are not conducted to the inner ear properly. So things that can cause it, genetic factors. So if your ear canal is too narrow, if you have a malformation of the cochlea, malformation of the middle ear, or anything like that. So something that just, you're formed weird, okay? That would be caused by genetic issues. Proven blockage, earwax. That's why if you go and complain about your ears and you can't hear, the first thing the auditory person's going to do is go, let's clean this. And you're like, oh, magically I can hear words. So if it's blocked, it's got to be muffly. Ankylosis of the ear bones. Again, ankylo meaning armored. So again, if you're into your dinosaurs, ankylosauruses are your armored dinosaurs. If you're having a bad day, whenever you had Jurassic World and the kids were in the hamster ball, the dinosaurs, the Indominus Rex killed right before he tried to eat the kids. Those were ankylosauruses. So ankylosis of the ear is where those bones get little kind of bone spurs, similar to what people would have in their heels. And if you get bigger bony plates, they don't vibrate properly. They can't push on each other properly. And it interferes with the vibrations going across that cavity. Otosclerosis, this is where your stapes actually fuses to the oval window. And if it fuses, it can't push against it because it doesn't move. So you can have that problem. Injury to your eardrum, enough said. Exposure to loud noises. This is because if you have a really loud noises, it sets up bigger waves, more intense waves. And if those waves are too big, that can cause more sloshing than possible. So that's why sometimes after loud noises, you get ringing in the ears, because you over slosh. And if you over slosh, you keep stimulating hair cells, even though there's no sound present. Because instead of just the normal push and pull, you get the push and pull and a little bit back and forth. So the ringing is caused by too much fluid movement. This is also why sometimes you may go deaf after very loud noises, like a rock concert or shooting a gun or a bomb or something along those lines. So this can be temporary as that fluid settles. And of course, if they slap the hair cells too much, it could cause those hair cells to bend too much and they don't pop back up properly. So again, problems that have overstimulated those hair cells, but actually hasn't killed the hair cells yet. Or aging. As you know, as you get older, it gets worse, right? Yes, you'll be hearing that a whole lot. What? Say it again. So as you get older, your eardrum gets thicker, and thicker things don't vibrate as much. One of the first things you're going to lose is high tones. Okay, it's probably why a lot of people like bass in their music. Like, I can still hear that. But those high tones are going to be lost very early on. back when cell phones first became popular, there was a mosquito ringtone or the teenager ringtone. It was a ringtone that was so high pitched that typically you had to be under 20 to hear it. If you were older, your eardrum was too thick to pick that up. So kids could hear their phone ringing or their text messages going off, and the adults in the room. Ironic, isn't it? I heard that one. Right? But the adults in the room couldn't hear it. Now, you can go onto the computer. There's different sites that will, if you've got good computer speakers, they'll do the sounds for you. And you can, they'll just do different high-pitched sounds all the way to the lows, and you just click when you can hear, and it'll tell you how old your eardrum is.
Wow.
Yeah, it's fun, because then you're like, dude, what are you, 90? I'm like, no. Just been banned in high school and have a lot of music. I have problems. So again, as you get older, it's not going to be as great. Did you have a question?
Yeah. So when you randomly hear like ringing in your ears, is that a loss of hearing?
So that could be caused by several things. One, you could have some fluid movement, not enough to hear here, but just enough to move the fluid so the hair cells bend a little and they misfire. It can be caused by pressure bending those hair cells, and sometimes it could be a chemical imbalance, just like sometimes you feel an itch even though there's not an itch there. It's because you
Like
had a
the
random
geological pressure, like depending on where you live, like I guess barometric pressure.
Some people are sensitive to barometric pressure. Usually with barometric pressure, people tend to get headaches. So that's
Okay.
why you'll have a lot of people get a headache when weather changes, because you're feeling that pressure, but it's not enough to register as a sound.
Is that what happens when you go to Colorado? Like that you get that pressure in your head?
Part of that kind of pressure is when you go up in altitude, air expands, and in the middle ear cavity, that air expands and it prevents things from moving properly. So you feel that bubble until you chew on bubble gum. Same thing with airplanes and stuff like that. So that one is air in the middle ear cavity, which could cause conduction deafness. You're muffled a little bit before that air. So when you pop your jaw or chew bubble gum, that helps to move that eustachian tube, so it lets the air out that way. So if you have anything that causes too much pressure in that fluid, could cause that ringing in the ear.
Okay.
So sometimes it's a neurological problem. So that's why you can take some. There's those lipoflavonoids or whatever that pill you can take to help with the ringing in the ear. That one's affecting how neurons fire. So it's doing nothing for your ears, but it's basically telling your neurons not to fire so much coming from the ear.
So like sometimes when I'm studying for a while and I'm taking the test too, it happens to me where I feel like I'm deaf, like I can't hear. Why is that?
Because I affect you deeply.
I'm just like, yeah, I just feel like I can't hear. Maybe because it's too quiet of a noise or what?
There's some stuff that could be going. Do you grind your teeth when you study?
Do I grind my teeth?
When you study, like really set your
I don't know,
jaw.
but I've been grinding them lately when I eat.
Oh.
Well, if you lock your jaw, that's going to affect air coming in and out. So that could cause air pressure bubbles in some cases. So some people will have that. And your ears are one of those sensations that you could easily block through the thalamus and so forth. So you may still be getting the sensations, but you're not getting the perceptions because you're concentrating so much on something else.
And like he was saying, like I have that ringing on my left ear because I had a car accident and the airbag hit me hard. So like I didn't have it for a while, and then I came back and then I feel that little ringing on my ear.
So that one's physical trauma to your cochlea. So you actually damaged those hair cells. So if any of them are broken and trying to heal, they'll misfire as they're trying to function again.
But they still like restore, they still like heal.
They can. So that's why you'll have like some people after really loud noises may be deaf for a few days, but after a week or so the hearing starts to return, depending on the severity of that noise. So it may take a few weeks to months for hair cells to replace themselves and heal properly.
I mean, but it's been like years now, like 3 years.
Well, you're just damaged.
Yeah.
You have problems. Just get that fixed. No. Again, neurological damage may take years to fix. Again, with our peripheral nerves, if you damage any of those hair cells, severely, you have to regrow just like you would any other nerve. So the swan cells have to rebuild and all that kind of fun stuff that we learned in A&P1. So it may just take a while for those to happen. Okay. So if we have problems with conduction, hearing aids help, because basically hearing aids turn up the volume. That's all they do is amplify the sound. So they replace the tympanic membrane if you damage that. They can crank the noise so intense that it vibrates through all that crazy mess and so on. So if you have somebody that has a hearing aid, you know they have conduction deafness. They have no physical damage to their nervous system. They have problems just getting from the outside to the inner ear. Then we have nerve deafness, also called sensorial neural deafness. This is damage to the peripheral nervous system. So those neurons that are going from the cochlea to the brain. So these guys, again, can be because of impairment damage to the cochlea, cochlear branch, vestibulocochlear nerve, all the way till it hits the brain itself. So causes, diseases. So any disease that can destroy the nervous tissue can cause deafness. So if you have multiple sclerosis, that causes paralysis, you could end up having multiple sclerosis that causes problems with hearing. Because again, it's not like your disease goes, no, not these axons, just these other ones. They'll hit any of them. So you can have that as a side effect. Some drugs, don't do drugs. But again, any drug that alters neural functioning. Okay, so this is why sometimes you'll get really weird side effects. It's kind of like we've all seen the commercials now. If you have depression, you might have tardive dyskinesia where you have a twitch somewhere. That's because that drug mimics a neurotransmitter to make some brain cells happy. And unfortunately, it makes the motor area happy. And when it gets happy, it makes you twitch. Okay, so sometimes we'll see that side effect. If it affects the nervous tissue, it can affect any part of the nervous tissue. So you could have issues hearing with certain medications. And of course, extremely loud noises. Not only does that slosh more, but if that tectoral membrane slaps those hair cells too much, it could actually damage or kill those hair cells. And of course, once those hair cells die, they're not going to come back. They could repair if they're just slightly damaged, and that may take a while, as we mentioned. But if they die, they're just gone. So you're not going to be able to hear what that hair cell would have processed. So you may have some hearing, but miss some of those tones out there. Treatment. This one cannot be corrected with a hearing aid. It doesn't matter how much you yell at the person. If the nerve isn't firing, it's not going to help them out. You may need surgery. This is where you get cochlear implants. So with the cochlear implants, again, you can tell that because instead of being in the ear like a hearing aid, it's behind the ear. And that's usually the battery pack, and it hooks up to magnets that are embedded in the skull that go and communicate to the cochlea. What the cochlear implant does is it does the translation. It does the job of those hair cells. So it picks up the sound waves and it turns it into electrical transmission, which is just like an action potential. So it's going to fire for the hair cells. So if you have issues, again, with your cochlea, you can get that replaced surgically. And of course, medical treatment if it's a problem that can be caused by drugs or altered by drugs. Yes, ma'am?
So what happens when I had surgery last year and they put something in my IV and it relaxed my whole body, but it felt like I could not hear. And I don't know if I was so high that I just was interlocked on something.
You got the good stuff.
I feel like I could just not hear. And even when I came out of surgery, I was like my mom was talking to me and I seen her mouth moving, but I just could not comprehend what was going on.
Well, you got to think a lot of your pain medications, a lot of your relaxing medications, how they work is they stop neurons from firing. Because if this neuron can't fire, it can't tell you it hurts or it can't stimulate you. And again, drugs aren't going to pick and choose. So you may have actually been dampening the firing of your neurons coming from your ears as well. So again, those drugs aren't picky. They're not like, let's just relax the muscles and leave everybody fine. No, they're going to hit any neuron and affect all neurons the same way, including sensory ones.
What about when you pass out? I say sometimes when you pass out, your hearing comes losing.
Your thalamus shuts down. So again, A&P1 we talked about. The thalamus is that gateway. So it's why you can sleep with your eyes open and not see. When you are certain stages of sleep or unconsciousness, your thalamus prevents any sensory from getting into your brain. So you could yell at, that's why people can sleep through their alarm clocks. Even though it's a really loud alarm clock, they're like, I didn't hear it. It's because the thalamus was down and it wasn't getting into the brain. So when people pass out, you have physical shutdown, that's the reticular activating system, And then you have the sensory shutdown, that's your thalamus. So sometimes your body wakes up before your sensory does. That's where you get things like sleep paralysis. But essentially what you're getting is sleep paralysis in your ears. No one knows my ears are paralyzed. They just get that.
Is that why you can turn off your alarm but still be asleep? Like, okay. Yeah, because I have a problem with that.
You're like, and I'm done. Your body's like, just conscious enough. That's okay. I always had to have my alarm on an annoying sound because growing up, my parents had the alarm set to radio, and I would just sing in my sleep. And like, you're not awake, but shut up.
Is that why you can like, sometimes my mom, like, especially in the morning, she'll say like we had a full on conversation, but like, I just won't remember it. Like, she'll tell me like, wash the dishes when you wake up. Dishes will not be washed when she gets home. I don't remember that conversation.
Yep. Thalamus is shut down, but your body isn't. That's the same thing. It causes sleepwalking, sleep talking, all that kind of stuff. Thalamus problems. Central deafness. As the name suggests, this is damage to the central nervous system. So we have, again, conduction getting there. We've got peripheral nervous tissue damage. We've got central nervous system damage causing deafness. So central deafness, damage to your brain. Okay, so this can happen after a stroke and it kills some of the cells in the temporal lobe. This can happen after a brain injury of a car accident, that kind of scenario. So somewhere between hitting the medulla, going through the midbrain, through the thalamus to the auditory area, somebody's not doing their job. So again, this is pretty rare because it does require brain damage. So usually if you have brain damage, this is the least of your worries because you can die from that. So there's no correction because there is no correction for brain damage. So if you've had a patient who had a stroke and they're like, and then I lost hearing, you're like, yeah, I know where your stroke was, temporal lobe. Again, this is why your doctors ask you all those questions when you have a head injury. Can you do this? Can you feel this? Can you hear this? They don't really care about your ears. They're making sure your brain part that processes your hearing is working properly. So you can guess where the damage is based on what kind of sensory stuff can we not pick up, or motor things that we can or can't pick up. Any other questions about hearing? So equilibrium. So again, when we have equilibrium, we've got static equilibrium and dynamic equilibrium. Static equilibrium is when you're standing still, you're static. So if you're sitting and you're so you don't fall over out of your chair right now. If you're just standing, that kind of scenario. Dynamic equilibrium is equilibrium while you're moving, while you're being dynamic. Now, of course, as we learned in A&P1, there's a lot of stuff that plays into equilibrium. We've got our proprioceptors that tell us where our body is, what's contracted, what's relaxed, all that kind of fun stuff. We've got our eyes. This is why, again, spinning with your eyes open gives you a different feeling than spinning with your eyes closed. That's why, fun houses that have the spinny walls, even though you're stationary, will make you really dizzy. And of course, people get motion sick watching roller coasters and stuff because eye things. And of course, ears. Now, even though obviously eyes and your body helps with equilibrium, we're just going to concentrate on the ear thing. Okay, so we're going to ignore the eye contributions and the body contributions because we're talking about ears. We're not talking about eyes and the body. So static equilibrium refers to orientation of the body, mainly the head, because that's where your ears are, relative to the ground. Essential for maintenance of posture as we sit or stand. So again, you don't fall over or get dizzy just sitting still. The organ of static equilibrium is the macula. So again, we have the three divisions of the inner ear. The cochlea is your organ of hearing. The organ of static equilibrium is your macula. So when we look at the macula, we've got two of them in the vestibule, that middle part of the inner ear. And it's going to have one in the utricle and one in the saccule. Again, weird words. I don't know who labeled these guys, but they're just fun to say after a while, right? It's like the utricle and the saccule. My later close to Venus hits Volkswagen. So anywho, you have these two guys that have the macula sitting within that vestibule, that space. Now it's going to have hair cells. Okay, so all of the components of the inner ear, whether it's hearing or equilibrium, both types are going to be based on hair cell activity. Now these hair cells are set in a gelatinous membrane. Okay, so like a sheet of jello. And within this sheet of jello, we have what are called otoliths. Again, oto means ear and lith means rock. So we do have little tiny rocks inside of our head. So the next time someone goes, what, you got rocks in your head? You can go,
Yes.
little microscopic guys, helps me do it. They're actually made out of calcium carbonate. Calcium carbonate is something that any animal that can be crunchy can make. Calcium carbonate is what coral make in order to make coral reefs. It's what you're going to find in sea arthropods like lobsters, so you can't eat their shell, that kind of scenario. So everything from really simple guys like cnidarians, corals and things, all the way up to us can make calcium carbonate. Limestone. Okay, so that's why some of your limestone are fossilized limestone, like the ones you get from Austin that have the fossils built into it. That's made from coral, or you get limestone from like around here from caliche and stuff. But anyway, limestone, that's what it is made out of. So when you have rocks, we all know rocks respond to gravity, right?
Mm-hmm.
That's why we throw them at people. They're going to fall. So what happens, you've got these rocks suspended in this sheet of jello with the hair cells. And they're going to respond to gravity. If you're not moving, they don't move either. If you lean to the side, the rocks lean to the side. It's going to bend the hair cells, and you're going to pick that up as, oh, I'm leaning to the side. When you stand back up, the rocks reposition, the hair cells straighten back up, you're standing. These are the guys, again, as we talked about in lab, they respond to gravity. So when you're in an elevator, you go up, that presses down on those rocks, they're going to respond to gravity, and you're going to feel that I'm going up. Okay, this is why if you've ever been in an elevator that's too fast, it can kind of make you a little motion sick. Only been in 2 of them that were that bad. The W in New Orleans and one in a gold mine up by Cripple Creek, Colorado. You can go down into a gold mine. It's a lot of fun. Anywho, so you're gonna feel that because it's those rocks. When the elevator goes down, the rocks float up, and then you feel that, oh, I'm floating kind of scenario. These are also going to respond to car movements. So these are the guys that freak you out if you get car sick. So part of the reason why some people get car sick is because their eyes are saying, I'm moving. The dynamic equilibrium says, I'm not moving. And these guys, if they're sensitive, say, I'm moving. And if you get multiple cross communications where one part says I'm moving, one part says I'm not moving, your brain's like, bleh. Okay, it just can't handle that. Okay, so this is why some people they only get car sick in the back seat. Okay, that's because it interferes with how they're processing everything. In the front seat, they can see things going and it works out for them. It's one of those weird things again because the way you process sight and how sight can give you vertigo and motion sickness. Okay, so these are the ones if you're walking on a bus, it makes you feel like you're going faster than you normally would, or if you stop, you feel sloshy if someone stops too quickly because these rocks are like, hey, and you're going to pick that up. Yes, ma'am?
Sorry, another question.
Mhm.
We were talking about people with alopecia, since they have trouble growing in like hair, do they have problems with hearing?
It's not the same kind of hair.
It's not.
Yeah, so that hair again is keratinized skin cells. They're epithelial. They're just called hair cells because the way the neuron is set up, it's got prongs that look like hair, but it's not made out of the same structure. Oh, that'd be sucky, right? I'm sorry, I'm bald. I can't hear you. Things you can do.
So, like how you said with gum, it kind of helps with the pressure. Is there anything that helps with the nausea and everything, or is that just something that, like
So-
you said, you have to see it in order to kind of fix what's going on?
Your brain has to be able to process things. So if it can go, okay, I'm seeing this, I'm feeling this, my ears are telling me this. Some people's brains are able to kind of tease out, I'm not really moving, it's okay. Other people's brains are like, too much, I just can't do it. The only way to stop neurons from being crazy is to calm them down. So that's why downers, Dramamine is a sleepy, so it's a downer. So this is why you don't take Dramamine and caffeine. Because you're drinking your Coke, that's going to make your neurons fire faster. You're taking Dramamine, that's going to make your neurons fire slower. You're still going to get motion sick because you're counteracting. So you should only drink water with your Dramamine. That way you don't get the upper and the lower that counteract each other. Okay? Or there's also that, it's called Calms, which is just a watered down version of Dramamine. It's a sedative. So any sedative that slows neural activity will help with motion sickness. Just sleep through it, you get better. So there's this chick and her vestibule with the utricles and the sacule. I don't know her name, so she's a chick. Okay. Here's the macula in that one, the macula in that one, and we can see we've got that little jelly layer, and you're gonna have those hair cells. So again, you're gonna have this structure of the neuron with the dendrites all straight up instead of going in all different directions. So that just makes them look like little hairs. And we've got the little otoliths. So those guys are going to respond to gravity, and as they pull the jelly layer, that gelatinous membrane is going to make those hair cells bend, and that's going to send off an action potential that says, hey, I'm leaning in this direction or that direction. Dynamic equilibrium refers to maintenance of the body position, mainly the head, in response to sudden movements or a change in the rate or direction of movement. So, moving. So this is going to be those semicircular canals, and this is why we have three, because we live in a three-dimensional world, right? You can go forwards and backwards, side to side, up and down. So we're going to have a semicircular canal for the forward and backward. We're going to have the semicircular canal for the side to side. We're going to have the semicircular canal for the up and down. So they're all positioned to make the best arrangement to slosh properly. Okay. So within the semicircular canals, you're going to have a continuation of that membranous labyrinth that is filled with the endolymph. And as you move, the endolymph is going to slosh back and forth. And at the base of each one of the semicircular canals, you have that swollen area, that ampulla. And within the ampulla is where we're going to have the crista ampularis, the organ of dynamic equilibrium. So cochlea, organ of hearing; macula, the organ of static equilibrium; crista ampularis, the organ of dynamic equilibrium. So as we slosh back and forth, again, the crista ampularis is going to have that little cavity filled with endolymph, and the cupula, the little jelly blurb that has the hair cells in it. So if we slide one way, we jello jiggle that way. If we slide the other way, we jello jiggle that way. And you've got three of those all jiggling based on the sloshing, and we're going to send those off to the brain for processing. So we pick up movements in all three directions.
So when we're naming the canals, would you put semicircular in it, or would it just be anterior canal?
Semicircular.
Semicircular.
Yeah, full names. So there's a close-up of our crista ampularis, our little cupula, made out of just basically a jelly blurb, almost like a Hershey Kiss of Jello. Well, think of all the fun foods you can make that are kind of like science. You have sheet Jello with grapes in it. Look, it's a macula. Enjoy. Okay, so here you would have those little hair cells. So if we jiggle this way, we bend this way, and we're going to pick that up as movement. We jiggle the other way, we bend the hair the other way, we pick that up as movement. Now, both static and dynamic equilibriums travel along the same route. So this again is why we can get a little bit confused in our brain, because our brain can't tell if it's the crista ampularis firing off or is it the macula firing off. We're going to have the same sensations coming in from both of those. This is why you can still get motion sick even though you're not moving if you perceive that you are moving, because we have the inability to distinguish motion issues versus static issues when it comes to equilibrium. So both of them are going to travel out through the vestibular branch of the vestibular cochlear nerve, and it's going to come in at that crack between the pons and the medulla. So as it comes in, it's going to shift directly, kind of skirting the top of the medulla, going through the pons to the cerebellum, so we can process. So most of the time, we're not going to be aware of these sensations because they're not working consciously. They're there just to make sure your body can move like it's supposed to. So at this very moment, you can't tell the degree of tilt in your head because you're not processing that. That's not the job of the conscious brain. It's the job of that cerebellum. Okay, so there it is. So we can see the different axons leaving all three of the crista ampulari. That's funny, plural. And then, of course, the utricle and the saccule coming through, joining up, coming into that crack between the medulla and the pons, and then hitting those neurons going straight to the cerebellum. All right, disorders with your ears other than deafness. You can have Meniere's disease or syndrome. Some books call it a syndrome, some books call it a disease. So this is a functional disorder dealing with the functions of both the ear, inner ear cochlea, inner ear, the macula, inner ear, the crista ampularis. So it's going to affect functioning of all parts. so it can affect how we hear, it can affect how we deal with balance and equilibrium. So what happens? You have an increase in endolymph. We don't know why, okay? The cause is unknown, and that's one of those things that if you have a disease and we don't know the cause, you can't cure the disease because you can't fix what you don't know. All you can do is manage symptoms and try to prevent further damage. And this is something that unfortunately a lot of people don't understand. It's kind of like when they're like, we're looking for a cure for Alzheimer's, we're looking for a cure of Parkinson's. We don't know what causes it. You can't fix if you don't know what the problem is. All you can do is manage. So we'll never have a cure for Parkinson's until we figure out what the hell causes Parkinson's. We can't have a cure for cancer if we can't figure out what causes cancer. We're learning. Now we know there's a lot of DNA involved in that, all that kind of stuff. But if you don't know the cause, all you can do is manage the symptoms, try to prevent it from being worse. So at this point, this isn't a fixable thing. This is a manageable thing that we're dealing with. So you have an increase in endolymph. Endolymph doesn't really cycle like a lot of parts of the body. Now the endolymph again is in the membranous labyrinth. So at first, if we have an increase in endolymph, it's going to push outward against that membrane, and that membrane is going to push into the perilymph surrounding it. But unfortunately, the perilymph can't move a lot because it's bound by the bony labyrinth, and bones don't give. So if we can't press out, all we can do is press in. And if we press in, we're going to start pushing on those internal structures. We'll start pushing on hair cells. So we'll have different stimulating results of pressing on those hair cells. So we'll pick up sensations that aren't really there. And of course, if we keep pressing and pressing, eventually we will crush them to death. You just have to manage and hope that you don't crush those little guys. Now, because the membranous labyrinth is continuous between the cochlea through to the semicircular canals, it can affect the semicircular canals. It can affect the cochlea, causing problems with balance and equilibrium. So our symptoms, fluctuating hearing loss. As we have a bubble of endolymph pressing on those hair cells, when we first press them, we'll get ringing in the ears, so that tinnitus. And then if we keep them pressed and they can't pop back up, they can't fire anymore because you've prevented them from opening up any more sodium channels. So you can have hearing loss. So there's cases where you have a day or two you can't hear anything, and the next day you can't. Until that excess bubble of endolymph shifts, you're not going to be able to hear that. And it may be complete deafness. It may just be certain tones that you can't pick up depending on where the bubble of endolymph is pressing at that time. If that bubble of endolymph presses on the cupula, it's going to bend the hair cells, and we're going to pick up that as a moving sensation. And of course, if you're, have one guy saying I'm moving, two guys saying I'm not moving, that's when we end up with things like vertigo and dizziness. So you may have waves of dizziness happening, and depending on how that endolymph flows, that wave of dizziness, that ringing in the ears, that hearing loss may last for a few minutes to a few hours to a few days. And again, all you can do is manage. So you can take medications to try to lessen vertigo symptoms. You can lay down. You can try to not move a whole lot. But until the episode passes, there's not a whole lot you can do except manage those symptoms. And again, since the cause is unknown, there's nothing really we can do except for management. Ositis media, okay, itis, inflammation, oto meaning ear, and media meaning middle. So this is an ear infection of the middle ear. And again, caused by anything that makes you snotty. So strep, flu, anything like that. So again, with those middle ear infections, you've got the issues with the infection, that hurts and all that. But if you have that buildup of fluid, that can interfere with your hearing, as we've mentioned. If it causes scar tissue, it can cause permanent damage. So again, this is why when you have a kid who has repeated ear infections, they try to get those treated as quickly as possible, put the tubes in to prevent more ear infections. Because if you build up scar tissue, especially either around the bones or the oval or round window, that could interfere with hearing for the rest of your life. So you could go deaf from having too many middle ear infections in severe cases. Always want to treat those guys. Impacted crewmen, again, too much earwax. So there's lots of different things you can get off the internet to help suck the earwax out of your head, or you can get those creepy candles. Those are just scary. I don't want to set anything on fire next to my hair. It's like I keep picturing like a Michael Jackson Pepsi commercial probably.
So do those just
I like
liquefy
it,
your
but-
earwax and allow it to run out? Okay.
Yep, they just liquefy everything, warm it up.
They're cute, they're cute.
So it drains.
It goes down.
It's creepy. Whoosh, gone. But in severe cases, you may have to get it professionally cleaned, because unfortunately, when you use a Q-tip, if you keep jamming stuff in, it can pack, and then of course, you're not gonna be able to hear past it.
So this is excessive earwax, not compacted. Or it could be both.
It could be both. So if you do just normal ear cleaning, but you shove it in instead of pull it out, then it's gonna impact on itself. Then you'll end up on a video on Facebook or something, right? Look at this. Right, motion sickness, the functional disorder brought about by repetitive angular, linear, or vertical motion. Now with this disorder, again, it's all in how the neurons are firing and how the brain is responding to overstimulation. So there's not a anatomical component to this. You can't look at that person and go, oh, well, his cochlea is shaped funny. He's got a problem with equilibrium. That would be the wrong part anyway. So it's one of those things that you just have to deal with. Of course, motion sickness, vertigo, characterized by nausea, vomiting, all that stuff. So excessive stimulation of the vestibular apparatus by motion. Okay, so whether it's coming from the dynamic equilibrium or the static equilibrium, either one can overwhelm. Now, the reason why, if as we move about, we overstimulate the hair cells, they're going to have faster and faster action potentials. As those action potentials travel through by the medulla has the vomiting center. And if the medulla gets too stimulated, it just vomits because I can't take it, and you throw up. So it's just in passing that it's seen as a vomiting issue. Warning symptoms, basically all things that can happen right before your vomit. So when you vomit, your body prepares for it. It's kind of like stretching before a marathon. So things that your body does to prepare for the vomit happening. Yawning, that stretches your neck muscles, your jaw muscles, so you can open wide and let it out, and it stretches your pharyngeal muscles, so you can open those up. Salivation, you're going to prepare by coating your teeth in spit, so hopefully the acid doesn't wear away your enamel too much. Pallor, you get really pale because we're brushing blood to the core of our body, to the digestive system, to prepare for that muscle contraction to go backwards. Hyperventilation, just stress. Profuse cold sweating. Prolonged drowsiness, because when we yawn a lot, we perceive that as being tired. So if you're on an airplane next to a pale, spitty, sweaty, yawning person, move, it's coming. Give them the bag, it's gonna happen. So with our motion sickness, it can be due to just motion sickness, but unfortunately, some people, vision plays into it, because again, visual stimuli helps with balance and equilibrium. So you'll have people who are just sitting and can't go to an IMAX theater because 3D movement in a movie makes them vomit. Those sensitive people. Also emotional factors, because when you're really emotional, your not lymphatic, that'd be weird. Your limbic system is really amped up. We over-respond to a lot of stuff. So in this case, we would also over-respond to it. So fear and anxiety. So if you're afraid of the airplane crashing down and you're all going to die, that's more likely to cause and contribute to your motion sickness. So this is why they always tell you be calm, relax, and of course, as we mentioned, you take downers, things that are sedatives, so it slows down action potentials, it slows down, hopefully getting rid of your anxiety and fear, which is just going to contribute to the vomiting thing. Relax, it'll be okay. Big bad hair, questions about ears. Woo, hormones, are you excited?
Okay, yeah.
Yeah. Everyone's excited. All right, hormones, the reason why you are crazy. All right, so if we remember back in A&P1, to make sure the body functions properly, we have to maintain proper homeostasis, right? Our happy place. Now, if we need to respond quickly, we're going to use the nervous system for the extrinsic regulation, right? If your hand is on fire, the brain is going to tell your muscles to move. You don't need to send a hormone, but your hand won't be there when it gets there. So if we want to do a quick response within the next few seconds to minutes, we're going to use the nervous system. Of course, A&P1 was all about the nervous system and that extrinsic regulation. If we want to regulate something that takes a long time to do, like growing, that takes a while. Ovulating, that takes a while. Making sperm, whatever. If it's going to last and have to take hours, days, weeks, months, years, nervous system is, not built for that. It's built for speed. So if we want to do long-term regulation, that's when we're going to use the endocrine system to communicate with the body to regulate and do homeostasis long-term. Now, when we look at cell communication, how cells talk to each other, we have three different routes. Direct communication. All cells can do direct communication. This is where two cells that are touching can talk to each other. It's just like you, if you're sitting at a table with somebody else, you can talk to each other the whole day, no problem. Okay, so all cells can do this through little chemical messages. Paracrine communication. This is when you have a cell send out a chemical communication to nearby cells. I'm doing paracrine communication, so to speak. I'm talking to everybody in this room. People next door can probably hear my muffles, but they can't hear what I'm saying. Okay, so if the liver wants to coordinate getting rid of your weekend, or if you need your blood to clot in this one spot, you would use paracrine communication. It usually is stuck in the same organ that is being involved in the release of the chemicals and picking up of the chemicals. And then we have endocrine communication. If you want to talk to somebody in a completely different building, you have to have a cell phone to do that. And not everybody can have a cell phone. A lot of people have cell phones, but you got to pay for them and stuff, right? You got to have special communications through the air so you can talk using a cell phone. So only cell phone companies can do that. You can't buy a radio and talk through it, right? Right. So that's endocrine communication. Only certain cells can do that. Okay. So again, these cells are going to be our endocrine cells, hormone-producing cells. And that is the signal that they're going to use, just like a cellular phone uses cellular data sent through whatever network they have amongst their little wireless groupings. You're going to use a hormone sent from one organ into the bloodstream, and it's going to float to its target organ so it can affect the functionality of that target organ. So not everybody can do hormonal communication, only if you're an endocrine cell. Just like you can't talk to everybody unless you have your cell phone with you. And again, as mentioned, endocrine is going to be our long-term regulation, the extrinsic regulation, balancing your life over years. Okay. So as a reminder about glands, we have exocrine glands and endocrine glands. So exocrine glands, exo outside, so they go outside of the body into cavities. So they're going to use ducts to release their products. And again, I'm saying ducts like air ducts, not quack quack. I don't enunciate that word properly, kind of like when I say right and right. Sounds the same. So we're using straws, so ducts to get out of the system. So this is something that, again, we talked a lot in A&P1, sweat and oil, and we'll be talking about spit and digestive juices, all that kind of stuff are exocrine glands. Endocrine glands, again, are going to communicate internally. They do not have any ducts, so that cell just sits there and releases their product into the interstitial space, the space around the cells, and it washes into the bloodstream and then gets to where it needs to go. So the chemical produced by our endocrine glands are hormones. So you don't have the variety. We have a lot of different types of hormones, but everyone's a hormone. Where you're exocrine, it could be oil, it could be sweat, it could be tears, it could be all kinds of stuff. Now, we do have a special category of hormones called tropic hormones. Some people say tropic hormones, so whatever makes you happy. It's a multiple choice test. It's not auditory, so good luck. So tropic hormones, tropic hormones. These are bossy hormones. They're going to tell another gland to make its hormones. So when your pituitary gland tells your ovaries to make estrogen, that's going to be a tropic hormone. Or your pituitary gland tells your testes to make testosterone. They're going to use a tropic hormone for that. So when we have a tropic hormone, we automatically know that this is a hormone that regulates somebody else's production of hormones.
Where do tropic hormones come from?
Depends.
They can be made from several different.
Usually they're the anterior and posterior pituitary gland to do that. But some of the other ones, there's some other places where they can pop out. There's a dude and part of a woman, and all their hormone producing glands. So we'll be looking at all these different organs and the production rate. Same thing just with arrows. So we have the different hormone producing organs. Now, some of them we're going to concentrate a lot about in this chapter. Some of them, like the digestive tract, we're not going to look at those hormones until we get to the digestive tract, because even though they are hormones, they're system hormones. So your stomach releases a hormone that tells the intestines what to do. So we'll talk about those when we get to the digestive system. Some of them will double tap. So we'll talk about kidney hormones today. Well, not really today, most likely tomorrow into Monday. And then we'll also talk about it when we get to kidneys in the urinary system. The heart, we'll talk about it this chapter. We'll also talk about it when we get to the heart. So you have all these different guys producing signals that are going elsewhere to do a job. So we're going to start with the pituitary gland, okay, because it makes a whole lot of stuff. Now, the science way to say pituitary gland is hypophysis, okay, because it's below the hypothalamus and all that kind of fun stuff. So the hypothalamus controls the pituitary gland. We've briefly mentioned this in A&P1. Your hypothalamus is kind of like the mob boss, and the pituitary gland is kind of like the guy that breaks your kneecaps if necessary. They're not going to do it just for fun. They're going to wait till the boss tells them to do that, right? The hitman just shoot randomly. He's told what to do. So the hypothalamus will tell the pituitary gland when to make hormones, when to release hormones. Because of that, we're not really going to concentrate on the hypothalamus, because with the hypothalamus, it'll be this hormone tells the pituitary gland to make this hormone, and this hormone tells the pituitary gland to make this hormone. So it gets boring. Okay, so we're not really going to address hypothalamus directly, but just know if the pituitary gland does something, it's because it was told to do something by the hypothalamus. Now, the pituitary gland has two parts. It has an anterior lobe and a posterior lobe. They look very different under the microscope. They function a little bit differently. The posterior lobe is also called the neural lobe or the neurohypophysis, and that's because it's made out of neural tissue. So when you look at a slide, it's axons and dendrites and all the parts that we see in nervous tissue. The anterior lobe, also known as the glandular lobe or the adenohypophysis, that was made out of glandular material. So when you look at it, it looks like a big old sweat gland. Okay, so lots and lots of glands that are in it. So very different tissues, very different functionalities between those two. There it is, the pituitary gland hanging out. You may not have seen this too much in A&P1 because it tends to fall off the brain and get lost somewhere. So none of our models had it because they're in a cabinet somewhere. So our anterior lobe, which looks like a big old gland, like a big old sweat gland or something. And then our posterior lobe, that looks like neural tissue. Okay, so they're going to have different jobs and different functionalities. And this is just showing you the blood vessels. Because obviously, if your job is to drop off hormones into the bloodstream to travel the body, you need to have a lot of blood vessels. So you'll see tons and tons of blood vessels around both the anterior and posterior lobe, also up into the hypothalamus, because we are communicating again and telling the pituitary gland what to do. So we're going to go through. Now, when we look at this chapter, this chapter is set up a little differently. So typically, when we have a chapter, we talk about here's the body parts and the anatomy, here's the physiology, and at the end, we end with diseases, so we know the end is near, and we move on from there. So that's typical chapter setup. I'm not going to have that same setup here. We're going to have everything in little nuggets, okay, little modules, so to speak. So we're going to have, here's the organ. We're going to have the different hormones produced by the organ, and within each hormone, we're going to have the name of the hormone, the abbreviation of the hormone. Yes, you have to know the abbreviations. If you've ever seen a lab readout from a hospital, they don't say, human growth hormone. It'll just say HGH. Okay, so you need to know the abbreviations because that's what you're probably going to see a lot in medical realms. We need to know what its target is. Who is it going to go pick on? We need to know what the job of that hormone is. And then, of course, what's wrong with that. So instead of putting all of the diseases and defects at the end, I'm doing it throughout. That way, when we talk about growth hormone today, I don't come back next Tuesday going, remember growth hormone last week? Let's talk about what's wrong with that. So it's more nugget form instead of all diseases at the end. Okay, so a little bit different setup, so I didn't want it to freak you out. So we're going to look at the anterior lobe first. So our first hormone from the anterior lobe is human growth hormone, HGH. The drug form of this, or the other name for it, is somatotropin. Again, soma means body, and tropa means boss. It's going to tell the body what to do. So human growth hormone, guess what it makes humans do? It's so nice. All right, so it's going to target your skeleton and say, hey, man, make some bones, grow. It's going to go to your skeletal muscles, tell them to grow. It's going to go to chondrocytes, say, maintain your cartilage, do your thing, man. It's going to go to your body so you can grow. Once we grow, it helps us to maintain the size, right? You don't have to worry about reaching, 5'6" when you're 20 and then shrinking down to 4 foot when you're 60. So you're going to grow and stay the same size, relatively. Now, how it does that, it increases protein anabolism. Remember what anabolism is?
It builds.
builds, okay? Builds protein, okay? Builds muscle, builds the protein to make your skeleton, all that kind of fun stuff. It is going to increase fat catabolism, which is,
Crush down.
yeah, breakdown, like catabolism breaking down. So we're going to shift from using carbs and proteins as a source of energy and using fat. So we build muscle, we break down fat when we have this. This also decreases glucose use. So unfortunately, if you have too much floating around, it can cause hyperglycemia. Hyperglycemia is high blood sugar. So we're going to learn that most people, when they think of blood sugar, they always like diabetes, right? Or insulin. There's a lot of hormones that can cause high blood sugar. So even if you have normal insulin, you can end up in a diabetic coma if you have too much growth hormone. That's why you don't produce a whole lot at once, you do little at a time. It's also why they regulate this drug. Okay, so after things like steroids were banned from bodybuilding and sports, human growth hormone hit. Because what does it do? Builds muscle, breaks down fat. It's exactly what bodybuilders want to do and athletes want to do. And some people, heck, this is what got Sylvester Stallone in trouble.
What?
I know, he was coming back from Australia to America and he had human growth hormone in his bag and he didn't have a prescription. So it was an illegal drug. He was using it to stay Rocky size instead of being an old man because he's an old man. So this is also something they manage for now in sports and so forth. So it's on the no drug list that they test you for, especially in things like professional sports, baseball and things. And of course, other than building muscle, the downside is it can slip you into a diabetic coma and cause death.
So does breast milk have half of that hormone in it,
No,
or no?
no.
I thought breast milk had a portion of it in it.
No, there's a lot of misinformation about this guy.
Hmm.
Okay, so, not going to be impressed. Pathology, hypersecretion early on before you're done growing, you get gigantism. You're going to be really big. Hypersecretion as an adult, once your skeleton is done growing, your body is done growing, so if you have too much human growth hormone in your 30s, you get acromegaly. Acromegaly, because the bones are done, all it can do is affect muscle and cartilage. So you end up having abnormal cartilage growth, your hands get really big, your face gets really big. This is what Andre the Giant had. So look him up. That's why he was a giant. He had acromegaly. It actually led to his heart problems because it affected the connective tissues as well. So it ended up being a contributing factor to his death. Hyposecretion early on, dwarfism. Now there's lots of things that cause dwarfism. Warwick Davis, all the little guys that you see in Ewoks and stuff like that, that's not the same type of dwarfism. That's achondroplastic. This type, you're proportional. So you're completely normal proportions, you're just 3 feet tall. Okay, so in that case, usually they give you growth hormone to help you. And this is something we're seeing more in pediatricians, where if your kid's on the low end of the height scale, they want to give you some growth hormone so you can reach your midpoints, so you're not as short when you grow up. Hyposecretion as an adult, you get Simmons disease or pituitary cachexia. You get very tired, very weak. Okay? Now, as mentioned, there's a lot of misinformation about this guy. One, you'll hear it a lot in food, right? We don't give our things any hormones, right? Or that milk that's hormone-free. One, if you cook your food, you denature hormones. So you've never heard a man go, I can't drink milk, I'll get breasts. No. You've never heard a man say, I can't eat female cows, I'll get breasts. You never hear a woman, oh no, that pig was male, I'll get a beard. You cook your food, hormones are gone. So it doesn't matter if they were hormone fed. And get this, when they give hormones to cows, they give them bovine growth hormone. Are you a cow?
Yeah.
Biologically? No, you're not a cow, you're a human. I like how y'all all waited. I've been called. It's one of those, you're not a cow. So even if you were to be given bovine growth hormone, it's not chemically the exact same thing as human growth hormone. And when they talk about milk, one, they pasteurize it. If they can kill the bacteria in your milk so you don't get sick, that does denature any hormones. So who the hell cares? Unless you're eating beef or carb, and then it doesn't matter if your animal that you eat was on antibiotics. That just means they weren't sick. That doesn't mean if they were on hormones. It doesn't mean if you gave them Skittles to eat. There are some cattle ranches where they give them defective Skittles because it's pure sugar. It don't matter the food of whatever you ate. Because honestly, if you knew what your pigs ate, you wouldn't want to ever eat pigs. Or chickens. Chickens will eat anything, including each other. Oh yeah, chicken's all nasty. So cook your food and you don't have to worry about if they were on hormones or anything like that.
So
So
that thing's alive and never like, oh, kids nowadays are so huge because chicken has been like.
Yeah, it's a complete lie. The only hormone that affects humans actually comes from plastic, and it's a plant estrogen. So it will cause issues with fertility in little boys. Like everything's packaged in plastic in my house now. But it's one of those, you have to like have food sitting in a plastic bag for a week before even the tiniest amount of particle transference happens. So unfortunately, there's a lot of people that believe what they see on the internet or what people have told them, or the commercials where they're like, "Oh, we never give our chickens antibiotics." So like that just means your chickens get sick and die easier. Good job. Doesn't do anything for your body. Cook your food and it'll be fine.
So what about rare steaks?
Oh, nasty. I would be more concerned about getting worms, but if there's any pink in your meat, you can get a worm. Beef people have suppressed that study finding.
Wow.
They're so regulated.